Heart failure.
What is heart failure? Heart failure is a long-term chronic illness that occurs when the body needs more oxygen and nutrients than the heart can supply. This can either be due to an inadequate pump, systolic, or inadequate stretching potential, diastolic, both causes leading to a decrease in cardiac output, heart rate times stroke volume. Causes of heart failure. Causes of heart failure can include anything that causes the heart to work harder to pump blood throughout the body, such as high blood pressure, anemia, hypervolemia, dysrhythmias, and others. There are many different types of heart failure: right-sided versus left-sided heart failure, and systolic versus diastolic heart failure. There can also be a mix of different types of heart failure, called mixed heart failure. Systolic heart failure, or saggy heart failure, occurs when the heart cannot pump enough blood throughout the body, leading to a decreased ejection fraction. The ejection fraction is the percentage of total blood that is pumped out to the body by the left ventricle. A healthy normal percentage is anywhere from 55 to 70%. There is an increased resistance as the left ventricle tries to pump blood out to the body. This can cause the left ventricle to enlarge. Diastolic heart failure, or dense heart failure, occurs when the heart muscle has become stiff due to overworking and now cannot relax enough to allow for adequate filling of the chamber during diastole. There is usually a normal ejection fraction. Left-sided heart failure is most common and occurs when fluid backs up into the lungs due to resistance to blood flow into the left side of the heart, leading to pulmonary edema, congestion, and shortness of breath. Right-sided heart failure is often due to left-sided heart failure and occurs when fluid and blood back up into the venous system due to resistance of blood flow into the right side of the heart. This leads to systemic edema and fluid volume overload. Patient assessment or signs and symptoms. Signs and symptoms of heart failure include shortness of breath, or awakening in the middle of the night, or need to sleep in a recliner, crackles or wheezing on auscultation, edema of the legs, neck, and abdomen, ascites, etc. There are also fatigue, nocturia, cough, dysrhythmias, and others. Diagnosis. The most common way to diagnose heart failure is via an echocardiogram, or echo. This ultrasound of the heart reveals the ejection fraction, and EF of less than 55% can indicate heart failure and also determines the severity of heart failure stage. For example, an EF of 65% reveals that 65% of the blood in the left ventricles is pumped out to the body. Blood work can also be ordered to reveal a BNP level, beta-type natriuretic peptide, which is indicative of fluid volume excess. A BNP over 100 indicates fluid volume overload. Interventions. There are different stages of heart failure, ranging from mild to moderate or stages A through D. Interventions are based on what stage of heart failure the patient is in, and here we will just discuss a general overview. One of the most important interventions is to teach about controlling or limiting risk factors, such as smoking, diet, alcohol, and exercise. It is recommended for many patients to follow a reduced sodium diet. For example, limiting intake of salt to 2 grams, or 2,000 milligrams of sodium total in one day. 2,000 milligrams is less than 1 teaspoon of salt, or 2,300 milligrams for an entire day. Fluid restrictions may also be important, and this is based on doctors' recommendations. Where sodium goes, water flows, leading to an increase in swelling and cardiac workload. Weighing daily is also important. Patients should report a weight gain of 2 to 3 pounds in one day, or 3 to 5 pounds in 1 week to their doctor. Elevating the legs also promotes blood return to the heart and can help alleviate swelling. Medications for heart failure may also be ordered, in addition to these above interventions. These include ACE inhibitors, ARBs, beta blockers, diuretics, Natricor, Entresto, and positive inotropes. Each of these will be discussed in detail over the next few slides. ACE inhibitors, ARBs in the RAAS system, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers both work on the renin-angiotensin-aldosterone system in the kidney to lower blood pressure and decrease fluid volume. Let's first discuss what happens in RAAS. Renin converts to angiotensinogen in the liver, then converts into angiotensin 1 and angiotensin 2. The angiotensin converting enzyme is now activated in the lungs and kidneys. ACE inhibitors at this point block the conversion between angiotensin 1 to angiotensin 2, thus preventing vessel constriction and increasing blood pressure. Angiotensin receptor blockers also act here, except they block angiotensin 2 from binding to the receptor to cause the release of aldosterone. After ACE is normally activated in RAAS, aldosterone is released, leading to sodium and water reabsorption, hence increased fluid and blood pressure, and potassium is excreted. The end products of a successful RAAS include increased blood volume and blood pressure. Angiotensin converting enzyme inhibitors block the conversion of angiotensin 1 to angiotensin 2 during RAAS. This class of drugs often ends in pril, such as lisinopril and enalapril. Adverse effects include a dry cough or angioedema, swelling of the lips and face, due to ACE receptors in the lungs. Increased potassium prevents aldosterone from excreting potassium. Fatigue and dizziness, potentially from a low blood pressure. Angiotensin receptor blockers. Angiotensin receptor blockers blocks angiotensin 2 from binding to a receptor and activating aldosterone, thus preventing vessel constriction and fluid retention. This class of drugs often ends in artan, such as losartan and olmesartan. Adverse effects are less likely and include a mild dry cough, much more unlikely compared to ACE inhibitors, a high potassium, and dizziness. Beta blockers block the beta receptors in both the heart and lungs. Beta blockers block the beta receptors in both the heart and lungs. Beta receptors in the heart increase heart rate and cardiac output by dilating blood vessels. Beta receptors act in the lungs to dilate bronchi. Beta blockers block these receptors, leading to a narrowed blood vessel and constricted bronchi, decreasing the heart rate and potentially causing an adverse reaction of shortness of breath. Thus, beta blockers must be used carefully in patients with asthma. Beta blockers can also cause hypoglycemia unawareness, in which the patient may not realize that their blood sugar is too low. It's important to encourage them to monitor their blood sugar regularly. Other side effects include cold hands and feet, fatigue, low blood pressure, dizziness, and a decreased libido. Examples of beta blockers include drugs ending in lol, such as labetalol, carvedilol, and metoprolol. Diuretics. Diuretics prevent and treat fluid volume excess and edema in heart failure. They decrease blood return to the heart, preload, and decrease intravascular blood volume, afterload, by acting on different parts of the nephron. Be sure to monitor blood pressure, renal function, and electrolytes during treatment. There are 3 different classes of diuretics. Loop diuretics are the first line for heart failure and fluid volume excess. They act on the loop of Henle. The drugs include furosemide, torsemide, and bumetanide. There is a black box warning for ototoxicity. They also need to be used with caution in those with a sulfa allergy. They can also cause a low potassium level. Potassium-sparing diuretics block aldosterone and prevent potassium loss. They include spironolactone, amiloride, and triamterene. They act on the late distal tubule to the collecting duct and can cause a high potassium level. Thiazide diuretics, such as hydrochlorothiazide, are the first line for blood pressure. They inhibit reabsorption of sodium and water at the distal convoluted tubule of the nephron, leading to sodium, water, and potassium excretion. Side effects can involve a low potassium level, and caution also needs to be taken in patients with a sulfa allergy. Positive inotropes. At later stages of heart failure, positive inotropes may be prescribed to improve the heart's contractility. These include dopamine, Levophed, and digoxin. Digoxin allows the heart to pump slow, decrease heart rate, and strong, improved contractility. Thus, it's both a negative chronotrope and a positive inotrope. Potassium must be monitored during treatment with this drug because a low potassium can cause digoxin toxicity, in which the patient may see yellow halos. A high potassium can decrease the drug's effects. Strict heart rate monitoring is also important, and instruct them to hold the medication if heart rate is less than 60 beats per minute. Other drugs for heart failure. Nasiritide or Natricor is a recombinant BNP, leading to vessel dilation. Entresto is an angiotensin receptor neprilysin inhibitor. It increases natriuresis, leading to sodium excretion. It's very expensive at $450 per month. Along with nursing interventions and these medications, later stages and end-of-life stages of heart failure, surgery may be appropriate or even hospice.
Please write your text here.